shared care plans, where based on people's decision can support digitally enabled integrated care advance, both from personalization and from multidisciplinary work support. The question is, are you planning to include it in your analysis?
Yeah, I mean, ideally, yes, of course, but how this translates into specifically technological tools. Again, if I were to think very quickly about this one, I understand that this has both an organizational aspect and then following that a technological aspect. So anything that improves again this creation of different communities. Again, these communities is not just caring or care-related stakeholders or entities. It could be anything. It could be your friends. It could be the people at your work. If I understand that in the long term, your well-being, your individual well-being, is depending also on those other relations that you have. So yeah, absolutely. Anything that could improve that, we will try to consider that.
Perfect. And the second is, rather than a question, is a suggestion on the pillar on leadership and governance was only plans. Pilar is suggesting that we should include also elements of ethical and legal aspects.
Yeah, absolutely. Actually, when I think of that, I don't even think of in such an abstract way. To me, information sharing, particularly when it's of a particularly dedicated nature, as could be social information or health information, triggers to me when implementing a system, authorization, accesses, the security. When you try to exchange information, you're bumping with the GDPR. So again, that's why I asked before that question about remote accessing the camera of your home. I know we were never able to do that. We would put a camera at home, we wouldn't even record the video. We would just take the skeletons and try to process them, and we found incredible resistance to do that from the patient. So again, we need to be very, very careful with all those things. So yeah, we were always thinking about those two aspects. Ethical more rather than legal, but yeah.
Thank you, Jorge. I hand over to you, Sarah. The chat now is open. The mics are open. Cameras can be open if you wish. And we have an exceptional audience. So, Sarah, please, you continue.
So thank you very much for both presentations, because they were very impressive. And we've seen the technological, more concrete point of view, and then the theoretical and the framework point of view that we now try to fit together, and of course try to answer maybe some questions. The point is, how can we fit together these two points of view that we have seen? So a very concrete one and technological one, and one more oriented framework and policy. So the first question that I would like to start with is if long-term care need a specific digital health assessment framework. What do you think about that? And then we will understand what are key technologies that maybe are useful for long-term care.
The very first question that I have to go along your question, the very first question that I have is, what would be the objective of an assessment framework in long-term care? What would be the objective? Is it to validate that the solution is comprehensive enough, or what is the purpose of it?
It's for Jorge, I think, this question.
Yeah, but indeed.
Okay, so that's for the overall care environment, or just for the digital part?
The assessment framework that you are referring to is for the digital part.
All right.
So let's take the exercise, and that was my point. Let's take the exercise that now over the coming months you will liaise with our friends from Manresa, and then put all the components of their solution into your assessment framework. Into your framework. Let's imagine you do that exercise. What will be the results of this? What will we gain? What will be the added value of mapping the solution of Manresa into the assessment framework?
Okay, so the first thing, but again, maybe that's something that's happening on my head. The solution of Manresa, to me, it seemed extremely complex, meaning it addresses basically everything, every point, and
It's
and
very
every
rich,
procedure.
very rich.
Exactly,
Yes.
exactly. So the first thing I would like to do, if I wanted to evaluate how well that works, or if there are areas of improvement, is try to divide that into somewhere. So we're already talking frameworks, and we're already talking a digital model, like
Yeah.
what are you using for this specific part of the model? What are you using here? What are you using here? And having said that, once you're looking into that, I would be extremely surprised if all these areas would be equally developed, or we would be equally comfortable with how they are being implemented on both the professional side, or the technological side, developer side, or the patient side, right? So we would see different things there. So again, that points to granularization of the whole system as a first step to be able to better identify areas of improvement. And now that we know which is working better, which is going worse, of course, we need to be able to quantify that. We need to be able to try to identify what potential things we could involve into the solution so that we can make those improvements happen in reality. At least that's how I'm seeing that, and that's how I would propose we work in the project from now on. I don't know if that worked as an answer.
I don't know. At least it would be interesting, for instance, to do that mapping first without any how to say that, without any in a neutral way, without foreseeing something particular. Do that mapping, then do the mapping of another solution using the same framework, and then comparing them to see. But what will come out of that, for the moment, I'm not clear. And I'm not sure that such a framework will help Manresa to identify what is, maybe the objective, to help Manresa to identify what is missing. Maybe. Or maybe to compare that in another solution, they have an element that could be useful for them. I don't know. But so the framework may at least be useful. That's what I expect. May be useful to compare two solutions. And I don't know how, doctor, you feel about it. But that's one benefit. But more than that, I don't know.
Starting from a concrete point of view, if we think about the technologies, digital technologies that are very useful for long-term care. So we have seen that with the Manresa example, good practice, we have specific technologies that seem to be accepted and seem to be very useful for the users. So I believe that we should start also from that, because sometimes if we are just thinking about evaluation and framework, sometimes it's quite difficult to understand and we may lose the focus. So the focus is what we need, what these people need, and if they are using these technologies. Because I understood that, and for sure we have been discussing, there are some barriers. There are many points to discuss, which are also concerning the system. But if we focus for now on the technological part, and if you should list key technologies for long-term care, what do you think about that? Could you also with examples that we had, but also I would like to hear from people, from our partners from Laurel.
Keep in mind that I am not a technician, right? So perhaps what I'm going to say might be totally wrong. I think that my understanding is that when providing long-term care, or if you want integrated long-term care, in the way that Dino has defined it very well at the very beginning when he explained the context of the Laurel project, we are in a way looking into how services can be provided by different institutions or agencies can be provided around the needs of this patient, and in particular the needs of long-term care patients in the context of deploying these services at home or at the community level. That is basically the goal. Now, I think that there are different technological solutions, and I think that the one that has been presented by the people from Manresa is a good one that actually cover many of the functionalities that might be needed to provide this type of services in a reasonable way. For instance, an example can be having a personalized plan on how to align the different services around a given patient and how the different professionals will be providing the services to the patients time-wise. Now, this functionality can also be solved, can be solved in the way that has been presented by the people from Manresa, but also in other ways. Also, perhaps in different settings, they will have different solutions already in place that perhaps are less comprehensive, but that in a way are better alignment with their current traditions in terms of work practice and could work equally well. So what I'm saying is that perhaps the guidance is the functions that we need to actually cover, and then looking into the different technologies. And yes, I think that definitely this mapping that Jorge was suggesting can actually be good to measure or to provide clearance around the goodness of a solution in front of another, right? So better coordination or easier for the professionals, or better interoperability or whatever, right? But and this is important in order to make sure that these solutions are conformant with the needs, that you can certify the conformance with the functionalities that you need to cover. But on top of that, I think that it's about the functionalities, the one that guides the whole thing. Because at the end of the day, if you have this beautiful graph with the services that have to be provided by the different people around the patient, but actually you fail in providing the services, then no matter how smart it is, you fail, right?
Absolutely along the lines of Albert, but formulated from a different angle. I think one of the key areas of assessment is how these technologies, and it was very illustrative what Bartomeu has presented with all these different solutions, are contributing to integrating long-term care. So I think the dimension of integration is fundamental, and we have to put the focus. But if we zoom out a little bit, maybe a quality of care framework could be also very useful, because we can look at how technology is improving accessibility to services, how is making the services more effective, more safe. I think the fall prevention is clearly along this line, and how technology can make also service more equitable, and this is one angle that we want specifically to look at in the project. And then there is the discussion about resources, and finally the patient-centeredness that these technologies can provide. I think this framework of quality of care, enlarged with the perspective of also of social services, would be a very nice combination for the framework, but absolutely in line with Albert's point.
Thank you.
A question that I'd like to direct more towards Bartolomeo, in the sense that clearly your system is about care. Clearly it's linked very closely with a hospital, and clearly it's linked very closely with patients. I was just wondering about your experience of working with people on the social services side as part of this integrated long-term care, and whether you do presentations with people who have that more social care background, and whether you could do so in the future so that Jorge and the Laurel project people could bear that social service, social care part of integrated long-term care in mind. Thank you. And Tino, maybe if if you can translate Bartolome,
yes.
that would be great.
Bartomeu, la pregunta és per tu, específicament és el paper dels serveis socials en aquest projecte que has presentat, perquè dona la sensació que és molt des de l'hospital, però si ens poguessis dir quina involucració han tingut tant els serveis socials com els treballadors de serveis socials dintre del projecte.
La integració més important que hem fet és...
The different points. This project has been under the auspice of the social services. They have lead components of the project. One of the demonstrations of this is that they are not talking anymore about patients. They are talking about persons, people. They are using technology to avoid social isolation. The role of occupational therapists is tantamount. And also they have these plans that are addressed not to the persons with long-term care needs, but also to the caregivers, the carers, informal caregivers that are informal or formal caregivers that are together with the person. So the project is integrated project, and the social service, they have a representation. Bartomeu didn't say so, but in that slide with all the logos, you saw the municipality of Manresa, who is responsible for social services. And then you have the hospital, Altaya, one institution that was SAS, I think it's San Andreu Salut, right, Bartomeu? And they are responsible for long-term care, so it's a consortium actually from the health and social sector.
Thank you very much for the intervention. Just a couple of comments from the chat that are really in line of what you said. But Pilar said the people-centered care, fantastic, and also Luke highlighted the importance of innovation to collect data and adapt. Considering personal capabilities and preferences. And Mark, about the framework.
Yeah, I'm back to the question of the framework.
Yeah.
And trying to link what Bartomeu has presented and the work on this framework. And while I said at the beginning that not at the beginning, but I say that I see the framework as a means and as an instrument to compare integrated long-term care. It may also be back to the question of Tino, the point of Tino and Albert. It may be also a way to identify how to integrate healthcare and social care with the technology. But then that should be more focused on the different dimensions that are needed for integration, So the framework, as you see the slide that you show, Jorge, with the slide with all the different dimensions, I see it as potential interesting exercise to analyze the Manresa system and compare it with another system that exists. I see that well. But if now we want to identify how to integrate healthcare and social care, then we need another instrument.
Yep.
That's my impression.
Maybe not another. Again, the way I see at least the part of the digital framework, again, is just a tool, a number of boxes that we can use to better fit different functionalities of the platform and so on in different places, so that it's easier to see what's going on and it works, it doesn't work, and so on. So again, if I were or if we were to think how to integrate healthcare and social care, it's not that you need a different, completely different set of boxes. Is that probably you would need to better identify or better define what fits in the boxes that are already there, or adding more boxes that would involve what are the different aspects that are involved in integrating the part of the social care, which I admit is not something that is considered in the models that we have seen so far.
Yeah, and on my personal opinion, I don't believe that the theoretical approach will help us to identify this, unless we compare solutions back to back to see what works, or those solutions that works well and those that works less well. But it's my gut feeling, not more than that. But I see that Dr. Bartomeu, you are raising the hand. So,
Dic, ara, mira si és important que...
Yeah, this is rather than a technological aspect, is an organizational aspect. The social component is provided traditionally in Catalonia through two levels. One is the primary healthcare team, so under the healthcare sector, with a specific social worker that is working in the primary care team that can make the first evaluation to accept the patient into the program, and the social services that are provided by the local government, the municipality. In this project, they have coordinated this effort, so it doesn't matter if the patient is first assessed by the social worker from the municipality or from the social worker of the primary care. This will be done only once. It won't be duplicated as it happened in many other places, so it will be only one venue to enter into the program, and the coordination between the local government and the healthcare services is ensured.
I haven't heard anything so far in integrating this social perspective of the care that would not fit in the boxes. So if we have an additional role there, which is the social caregiver, one of the city council, right? That is an access point to the whole system. That just means in the overall platform, and here, Bartomeu, please correct me if I'm wrong. In the whole platform, there is an access point for this additional role, the social care, that triggers or can trigger different functionalities of the overall solution. But again, that's how I would see it if I was to systematize the description of the whole system. But I might be missing something big here.
És important, no, que una vegada s'ha fet...
So another element here is that when they are visiting the person at home, normally the social workers, they are involving the person in the care plan. So it's a shared care plan, but not shared between the health and social caregiver, but also the person in the involved in the care plan deciding elements that fits well with their daily living.
Però el pla de salut i pla social, eh?
Yeah, social and health plan.
So who will pay for a system? Because actually the system is very nice. But there are a number of dependencies. It's probably you probably have a good idea of how much it costs. You will have soon a good idea of all the cost of the dependencies of the actions which will be triggered by the systems and the resources needed to make it working effectively. But how much does it cost, and who is ready to pay for it? And how this will, won't we have questions of accessibility? So if the patient has to pay partially for it in the future, because it's not considered as a service which is absolutely needed for everybody, but more as a plus. So what is your current ideas and reflections about it?
Hi ha una part, evidentment, nosaltres és públic i...
Some key figures. The answer to the question, who is paying for this, is the government for the moment. So it's public funding for the project. And this is the plan for the future. There is no discussion about private contribution. Bartomeu is highlighting two figures. One is this project so far has contributed to reduce 37% the visits to the primary care center and to reduce 32% the visits to emergency department. and these savings are helping to liberate resources that help to get either the technology or more service at home of patients.
It has been incredibly interesting, both presentations, and I enjoyed them both. This question is for Dr. Bartomeu. When we have been participating in integrated care based on digital tools, at the implementation phase, we found many resistances from the healthcare professionals, particularly from clinical doctors. I understood that you have been addressing these resistances, and I would like to know more how you have been succeeding in the clinical doctors to accept the system and to use it. Because sometimes there's a divergence between the needs and the willingness of normal people, average people, to use, for instance, AI tools for supporting themselves and understanding what is going on with their health, and the natural tendency to be careful about the side effects and the responsibility of who is to be blamed in case you are using an IT system that is using AI to provide advice. And of course, you were talking about this decision support tool. So I was wondering about, first, how you address these resistances, and second, which is the process that is followed for assessing these technologies, these health technologies. How long or how do you do the testing once they are actually being implemented in Manresa? And congratulations for this amazing integrated care approach. I thought it was fantastic. Thank you.
Sí. Curiosament, la resistència...
First is recognizing that there is resistance at the beginning, because everything that is related to technology, particularly AI, is frightening people. So there is this sort of resistance, but he's emphasizing the fact that this model is not a technological model, it's not a technological offering, it's a new way of coordinating resources between the health and social sector and to work together in a collaborative manner. He interpreted your question first, how the technology is prescribed, and the answer was interesting. I want to translate it too, is that is the team, the health and social team, but particularly the social part, that is prescribing which technology will be useful for this particular person. If the fall prevention will be useful, or if other elements that are in this, like the bed that helps the caregiver to, or the informal caregiver to manage the patient. So it's a social prescription of the technology for the specific needs of the patient. Then I rephrase the question, how the technology is evaluated before it is used in this model. And he says that they do assessment process where they check not only the usability of the technology, but also technical elements like the safety of the technology. And they have a specific place to do so. They have a simulation center, a sort of living lab, where they test the technology first before putting this technology into place.
One of the key issues of the text of the call that we applied with the Laurel project was the fact that the European Commission is rather concerned about the difficulties actually to be able to cover, the expenditure, the cost that will be associated to long-term care. And the forecasts are not really good at all. Even the last report it has published a month ago from the Commission and the ECOFIN actually establishes that again, right? So the Commission already detailed that wanted us to explore better issues around social economy because it was clear to them that there was no way whatsoever that using only our public models based in taxation would actually cover that. Now, that strikes me a little bit because your statement, Dr. Bartomeu, was that this will be in the hands of the Department of Health and the Generalitat of Catalonia, which actually I think that it's not a reasonable estimation, taking into account the data that we have right now available. Any reflections about that?
Nosaltres hem fet el ROI, tot el retorn de la inversió.
That they have run a return on investment analysis, and the results is that there are savings basically because it has avoided duplication or even triplication or quadruplication that happened before. And also that the approach with the technology is that it's not technology buy-in, is renting technology that is used for a specific patient, but then is recycled for the next one. I think in any moment we have discussed about the eligibility criteria of this program, and maybe restricting the eligibility criteria makes the system much sustainable, that it will be like right for everyone without any connection with the real needs. So maybe this is another aspect on the sustainability block.
I would agree with that. Segmentation of the categories of individuals where you apply the system makes sense. Actually, it reminds me of the development that we undertook, in the early 2000s here, when we started to move patients out of the hospital with our home-based program with integrated handover to primary care. And actually, we managed to assess something similar, the return of investment, only looking at direct costs. That was a trick. So in terms of saving duplication of resources, the figures were much less good when we included indirect costs, right? And that was a trick, right? But we were quite happy with only limiting ourselves to direct costs. Yeah.
Thank you to everyone. Only one message. I think today was very fruitful discussion based on this experience that is more at the practice level, but there are elements that are at the system level of long-term care that are also worth to discuss, and maybe we can organize a second webinar a little bit more after the summer related to how to improve long-term care from a system perspective and platforms of sharing information between regions. So thank you for your participation and discussions, and we will continue with this exciting exercise. Thank you.